Thank you everyone for joining us this afternoon. So we are delighted to have Dr. Nathanial Nolan here to speak with us today. And he is a senior fellow in infectious disease here at Washington University. And he's going to share some information about the COVID-19 vaccine hesitancy. And so if you have any questions during the presentation, please type them in the chat box and then Nathanial will answer them at the end of the presentation.
Thanks. So let me just share my slides if that's okay. So as Rebecca was saying, I'm one of the infectious disease fellows at Washington University, and happy to be here and give you guys a talk about something that I think is really important. Feel free to put things in the chat or to unmute and stop me throughout the talk if you guys have questions. Some of this may be information you know, but I'm hoping to add some layers to things to allow people to feel informed about the vaccines and to be able to have conversations with patients and clients as they're kind of navigating what for many people has kind of become a bit of a difficult decision. So just some brief background, COVID-19, so that's what we call the disease, but it's caused by the SARS-CoV-2 virus, and that is a coronavirus that has the ability to affect humans. And this is just a pictograph of that there. The presentation can be variable, as we know. There's a large proportion of people that will be asymptomatic or have very mild disease, never requiring any hospital care. But a large proportion of people will have severe disease requiring hospitalization, maybe ICU level care. And there's a significant amount of people who unfortunately have passed away from COVID-19. And one of the biggest predictors of hospitalization and mortality is age. And I'm going to show you some data about that here in a second. This was taken from data just a few days ago. Overall, we are still in a pandemic across the world. Unfortunately, places like India are still struggling to get their numbers down. In the US, we've had about 32.3 million documented cases with almost 580,000 deaths. Worldwide, there's about 150 million documented cases, which is likely an underestimate, with over 3 million deaths. And I show you this here because I think it's important as we talk about vaccines and we talk about, a lot of people have trouble understanding the risks of transmission and things like that. And so this figure, I think, is helpful in that it helps people to understand when we talk about this incubation period, from the time that you get exposed to the virus to the time that you might have symptoms that would let you know you should isolate, quarantine, get tested, things like that. That may be days between the time that you're exposed and the time that you have symptoms. And in those days, you may be able to transmit the virus. And so that's one reason why this has been such a devastating virus and so hard to control, is that many people may be exposing others for a period of 1 to 3 days, even up to 5 days before they ever even know that they were sick. And that allows them to unfortunately infect other people during that time frame. The symptoms can be really variable, and some people will say that their only symptom was changes in taste or smell. Many people will have fevers, cough, will feel fatigued or have a low appetite. Somewhere around 40 to 50% of people will have significant shortness of breath, and that's what this word means, just shortness of breath. About 14 to 15% will have severe disease, and then 5% of those infected will need some sort of ICU level care and may ultimately expire from the infection. And this is based on CDC data, and this is just risk of hospitalization and mortality from a COVID-19 infection as compared to people in a 20-year-old cohort. So those in their 20s as the comparison group. When you look at people that are over the age of 65, they are 5 times as likely, if they get COVID-19, to require hospitalization, and over 90 times as likely to die. And that increases the older people get. And so one of the populations that we were trying to reach first with our vaccination campaigns were those over the age of 65 and those with comorbidities such as hypertension, diabetes, and immune conditions that might make them more susceptible. But that's the reason that we concentrated efforts on this population, and why we continue to concentrate efforts on this population that really can be impacted by their ability to get a vaccine. I want to give you just a bit of background about how vaccines work. So there are two ways that vaccines work to prevent illness overall. One is at an individual level. And so if you receive a vaccine, all vaccines work the same way in that they attempt to stimulate your immune system to make antibodies, which hopefully will prevent you from having severe disease if you were to ever encounter the coronavirus in the future. And so that, again, is at an individual level. And so you may have heard that even people that get the vaccine can still have asymptomatic infection or low-grade infection. But the goal is that if you have those antibodies, we prevent people from progressing to needing hospital or ICU level care, and certainly prevent them from dying. The second way that vaccines prevent disease spread is through something called herd immunity. And that's depicted in this graphic here. And so if we were to imagine a virus that for every person infected, that 4 other people became infected, you could see how that disease would spread through a community exponentially, which is what happened with SARS coronavirus. The reproductive number was not 4, it was actually only about 1.5 and maybe a little bit more in some communities. But for every person that was infected, other people became infected, and it continued to propagate that infection. Now, if you were to vaccinate a proportion of the population, what happens is if this individual unknowingly spreads the virus to someone else, you now have this barrier of individuals who may be immune to that infection. And so then you stop the spread beyond those initial contacts. And so we call that herd immunity. And so it's believed that about 50 to probably closer to 70% of the population will need to have immunity either through past infection or through vaccination to achieve herd immunity in a meaningful way that would allow us to return to normal lives. This is a bit of a busy slide, and I don't expect anyone to understand all of the science behind vaccines, but I think it's important for us to understand how these vaccines work so that we can have informed conversations with patients and clients. And so there are 2 main types of vaccines that we're using in the US. The mRNA vaccines, those would be Moderna and Pfizer. And each of those vaccines requires 2 doses of vaccine in order to be considered fully vaccinated. These are mRNA vaccines. And what that means is they contain something called messenger RNA. And this, in simplest terms, is a blueprint that your body can use to make spike proteins. And so what happens is you are given in the injection a lipid particle. So this is just, by lipid, I mean fats that you might find in your blood. Those contain this messenger RNA. Your cells can then use that to make these things called spike proteins. And those are the little proteins on the outside of the virus. Your body then says, hey, this isn't one of our proteins, and it makes antibodies. So then if you ever encounter a SARS-CoV virus, you now have antibodies that are circulating in your blood that bind to the outside of that and tell your immune system to attack it and prevent it from being able to spread throughout your body. There is no risk from this of getting a viral infection or of getting coronavirus from this. This mRNA particle actually is not very stable, and that's why these have to be kept very cold. And so in a matter of hours, these particles start to degrade. And so I know that people have been concerned because mRNA is a very new technology for use in vaccines, but it's actually very, very safe. I want to highlight just the studies that were done in order for the FDA to decide that these were safe for people and effective for people to use. And so I'm going to highlight 3 different studies, but the first is the Pfizer study. This started enrolling people back in the end of the summer of 2020. And over 40,000 people were enrolled and over 20,000 received the vaccine. And then the other 21,000 and some odd received what's called a placebo, which would be an injection in their arm, but it would just be salt water. It would not be anything that contained a vaccine. They then used 7 days after their second dose in order to start the clock as far as when you would expect there to be a difference between people being immune and non-immune. What this graph is, and I'll spend a few seconds here talking about this because you'll see this graph 2 or 3 more times in different contexts, is the blue line, people who were unvaccinated, and this is their risk of getting COVID-19. And then this red line is people who were vaccinated and their risk of getting COVID-19. And so you see, even after the first dose, day 0, dose number 1, even at 2 weeks before they ever got the second dose of vaccine, you start to see a split. So already you see people developing immunity and no longer being as susceptible to COVID-19 as far as the disease. In the trials, only 8 people who were vaccinated developed COVID-19, and over 162 people who were unvaccinated who got placebo were ultimately acquired COVID. And so this led to the calculation of a vaccine efficacy of 95%. Side effects were relatively common, and those side effects include pain at the site of injection. So this is a vaccine that really does a good job of stimulating the immune system. And so often people will have some pain and some redness at the site of the injection. Many people, especially after the second dose, described fatigue. Some people described headache. And there's a significant proportion, probably about a third, who had low-grade fevers after their second dose. Now, one thing I'll tell you is that a proportion of these side effects happened in the placebo arm. And so we know that anytime we do something to someone, whether or not it's seemingly innocuous, there is something psychologically that happens. And so some people that got just normal saline as an injection also experienced the fatigue, the headaches, and things like that. I think it's important to educate people on the potential side effects so that they feel warned, and also so they know that this is not something that is signal for something very bad happening to them. The Moderna study, so Moderna was approved after Pfizer. This study looked at over 30,000 individuals, and over 15,000 got the vaccine and over 15,000 got placebo. This is the same type of graph. So you see day 0, this arrow is, so this is when they were randomized. This arrow is when they got their first vaccine. And you see this arrow when they got their second vaccine. And you see even here, again, around day 14, 15, you start to see a split. So even one dose of the vaccine appears to be very effective at starting to increase someone's immunity to COVID. So 11 people in the vaccine group were diagnosed with COVID, and 185 people in the placebo group were diagnosed with COVID. So there was a vaccine efficacy of 94%. And what I should say is that these people that were diagnosed with COVID that got the vaccine had very mild symptoms. There were no deaths or hospitalizations in people that have got the vaccination. And we've continued to see that trend actually in some real world studies that I'm going to show you here in just a second. The side effects between the Moderna and the Pfizer vaccine are very similar. Many people will experience some pain at the site of their injection. This might be the same pain that people get after a flu vaccine that they get every year. Many people describe headache, chills, muscle aches, and these are all things that we are stimulating the immune system to create antibodies. And so all of the things that happen when you get a mild viral infection can happen at the time of that vaccine. And so again, it's just kind of the feeling fatigue, maybe a low appetite. I did not experience any of that. My wife had a little bit of a low-grade fever. But for the vast majority of patients, that resolves quickly within 12 to 24 hours. The second type of vaccine that we'll talk about that's available in the US is called a vectored vaccine, and this is Johnson & Johnson. I will compare this to the mRNA vaccine. So the vectored vaccine, the mRNA vaccine had lipids on the outside. The vectored vaccine has an inactivated adenovirus. And so this is a viral particle that can't actually replicate at all. And it contains DNA that encodes spike proteins. And so it works in very much the same way. Your cells in your body uptake this vaccine. It creates blueprints to make the spike protein. You make that spike protein, and then your body is able to make antibodies to the spike protein. And the nice thing about the vectored vaccines is that they're much more stable. They don't need the ultra cold storage. They can be at room temperature for much longer, and they don't need 2 vaccination doses. And so the J&J vaccine can be given as a single injection. This is the same type of graph that I showed you earlier, and this is the data that they submitted to the FDA. So over 40,000 individuals were in the J&J study. Over 21,000 received the vaccine. And again, you see here is day 0 when they got the vaccine. And at day 14, you start to see a shift in people's risk for getting COVID. And so people who got placebo continue to have a higher risk and continue to get COVID, and you start to see this level off. There was a lot of discussion about the difference in efficacy between J&J and the mRNA studies or mRNA vaccines. What most people don't understand is efficacy has to do with background rate of disease. And unfortunately, the J&J vaccine happened in different countries, but also at different times of peaks of disease incidence. And so what you saw is that there were countries where this vaccine was being rolled out where they were having a very high rate of disease. And so the efficacy looks less than probably it would have looked if it had been done at the same time as the mRNA vaccines. I will say that in the US, it actually performed very well as compared to some of the other countries. So the good news is that similar to those studies that I already showed you, we're gathering a lot of data now that says that these vaccines work very, very well, exceedingly well. And the largest study is from Israel, where they looked at over 570,000 people. These are people that actually got the vaccine. So 500,000 people got the vaccine, and then they matched them to people who did not have the vaccine. And even though in Israel at this time, they had variants spreading, they still saw 92% effectiveness in preventing disease. There's a recent study done by the CDC, and they looked at just people over the age of 65. And looking at those, that cohort, the mRNA vaccines, Moderna and Pfizer, were 94% effective against these individuals needing hospitalization. And then several studies have looked at healthcare settings. And so as you may recall, back in December, they started vaccinating frontline workers in the healthcare systems. And these would be people who would be relatively high risk because they're interacting on a daily basis with patients who actually have COVID. And we're seeing that time and time again, the efficacy is over 90% in these different hospital systems. There's a study from Boston, there's a study from San Diego, and all of these demonstrate just very, very good efficacy in the real world. And these vaccines seem to actually be very effective against the variants. And that's something that you hear a lot in the news and a lot of concern about variants. However, at this point in time, they seem that they are slightly less effective, but continue to offer a lot of protection. And the hope is that we don't actually need different versions of the vaccine in the future for the variants, that these vaccines will be enough. So in the US, we continue to vaccinate people, and we're up to a couple million people a day. Almost 150 million people in the US have received at least one dose of vaccine. We have started to enter a phase now where we actually have more vaccine than people who are showing up to get it. And that's something that is probably not unexpected. I think that there's a lot of hesitancy, and we can talk about the reasons for that hesitancy and the ways that I would address that. But it's important that people realize, and when you talk to individuals, that millions and millions of people have got it. And so I hear often in my clinic that they say, well, this, I want to see what happens with everyone else. Well, how many more people do you need to see it in? I mean, millions of people around the world have also gotten the vaccine. So, and we're not seeing a lot of signal for any harm. And I'll talk about the J&J vaccine and them pausing that here in just a second. So as far as questions that I get asked routinely, I get asked, are vaccines safe? They're very safe. You're likely to have some symptoms from it, symptoms of kind of muscle aches, of fatigue, of having low-grade fever. And that's actually, I tell my patients, that's actually good. You want that because it means your immune system has been stimulated and it's making antibodies. And so they're very safe. There is a concern about allergies. And in January, there were reports of people having anaphylaxis, which is a severe allergic reaction to vaccines. In all of the analyses that have been done, the risk of having anaphylaxis is less than 5 cases in 1 million doses. And most of the people that have that are people that had severe allergies to begin with. And what I mean by severe allergies are people who have had anaphylaxis before. And these are the people that carry around things like EpiPens because they have severe allergies. If you have a history of allergy, we actually have people stay at vaccination centers longer to be observed to make sure that they don't have any kind of reaction. Another question that people have asked in the past is about preservatives. Historically, those who have had concerns about vaccines were always concerned about the type of preservatives that were used in the vaccines. And these vaccines actually don't contain any preservatives. And they did that specifically because they wanted to make sure that they're, as an aside, any preservative that's been used in any other vaccine has been found to be very safe. But there is a lot of intention put into making these vaccines so that people would trust them and would trust the process. And so that's why these have to be frozen and stored in ultra cold storage and things like that, is because they actually don't contain any of the preservatives that historically people have had any opposition to. The J&J vaccine suffered a bit of a hiccup. So on April 13th, the CDC and FDA suspended administration in the US. It did not get suspended in other places like the European Union. Out of 8 million doses, or 8 million people that were vaccinated, there was a signal for the formation of clots. And this occurred in about 15 people. So that would be 1 per 500,000 people. And though that seems very scary to people, the risk of getting clots, the fact that they picked up a signal that you did something 8 million times and you picked up that it happened 15 is actually pretty amazing, and tells you how closely that side effects and the risk of side effects of these vaccines are being tracked. And so I think this is actually a story of success, because we have been tracking through healthcare people having any kind of reaction to these vaccines, and have been preemptive in the US about halting vaccination if we think that there's any risk of harm. I will tell you that women, young women, typically in their 30s are the ones that have the highest risk of these blood clots. Now, women of this age have a higher risk of blood clots in general, and that's typically due to estrogen. But their risk was about 5 per 500,000 vaccine doses. So they recently resumed administration of the J&J vaccine, and they did these calculations. And so even if they started the vaccine back at half the rate that they were vaccinating before, it would be expected that they would prevent 1,500 deaths from COVID by giving the vaccine at a risk of causing only 26 blood clots. And these aren't deaths, these are just people that have blood clots. And so the risk benefit ratio was felt to favor using the vaccine. So there are several other questions that I encounter frequently. One is patients that had COVID previously and they wonder, do I need the vaccine or can I get the vaccine if I've had COVID? And absolutely, you can get it. You likely have some protection from getting COVID again after having had the disease prior, but we have seen people who, as they get 6-8 months out from their infection, as some people are now, they get COVID again. And so we're recommending that they do get the vaccine. Unfortunately, early on, especially when we were having a wave here in this area in December, January timeframe, we had some healthcare workers who got the vaccine and then acquired COVID during their routine working within the first couple of days of getting the vaccine. And as I told you, it takes about 2 weeks after that first vaccination to really start to have immunity. And in that situation, we had some discussion about what to do, but we found that giving the second dose was okay and had no contraindications to doing that. And so many of these people, after they were done isolating from their COVID diagnosis, were able to get their second dose without any issue. Some people have been treated for their COVID with convalescent plasma or monoclonal antibodies. We ask people to wait for 3 months afterwards. And the reason being not that it's something that's dangerous, but that if you already have antibodies that are circulating against COVID, it might decrease how effective the vaccine is whenever you get it. These are some resources. So the Missouri state website for COVID vaccine guidance has been pretty helpful, and they have a frequently asked questions section that where you can go and get many of your questions answered. I think the CDC resources have been really, really good. And then I've recommended and referred people to this New York Times page, and this is actually free, even if you don't subscribe, but it has a lot of infographics that I think are helpful in helping people to, some of this stuff is not intuitive for people that don't do infectious diseases on a regular basis. And so some of these infographics I think can be helpful in wrapping your mind around some of the nuances. And so they have some really good infographics about how the vaccines were developed and how they work. And so at this point, I'd be happy to take any questions or to address anything I might have glossed over. I really just wanted to give this as kind of a quick primer with the hope that we would have plenty of opportunity for questions and discussion.
So thank you, Dr. Nolan, for a great presentation. That's really helpful primer. I had a question that I put in the chat and wondered if you could speak to it. I think there's a temptation with a lot of aging services providers to look at the vaccination rates among older people and think, we've already achieved herd immunity in that group. But could you expound a little bit about what herd immunity means? Does that include children? And I mean, if we have, it has to be the whole population, right? We can't just pick and choose. Okay.
Correct. Yeah. So, about, I think it's about 20% of the population in the US are children that would not currently qualify for the vaccination. And so we're now, it's going to be rapidly expanded to children. They're expecting this week that the Pfizer vaccine will be expanded, I think, to age 12. But yeah, so when we talk about the population, unfortunately, what we don't mean segmented portions of the population. It's not 70% of people over 65, 70% of young adults. It's 70% of the US, which means that actually we have to get more than 70% of adults vaccinated in order for us to have herd immunity across the US. And, fortunately, I think there's been some realization that maybe kids are not as much a vector as we thought at once, but certainly they have very mild and asymptomatic infections. And that's something that we've had to be thoughtful about especially as we open up schools and things like that. And so it becomes very critical that we vaccinate as many people as possible so that children who may not have access to the vaccine can continue to go about their lives.
Thank you.
I also see a few questions in the chat from Emily Somerville. She said, can you talk about how mRNA technology has been used in other ways, like for cancer treatment, et cetera? Thinking about how the mRNA tech is new for vaccine use, it's not really new technology in the medical world.
Yeah, so that's exactly right. So this is the first time that we've been using mRNA in a large scale in humans as a form of vaccination. But for decades, we have been using these mRNAs in people as a way to help people make proteins that they otherwise might not make. And so this is actually, there are some diseases that are single gene disorders where we've been able to help people make proteins that they wouldn't otherwise be able to make because they have a genetic disease. And I think that this is actually a really exciting thing for healthcare in general, because I think you're going to see a rapid expansion of the use of mRNA in other diseases. And I think you're going to see it be very beneficial for certain diseases. One thing that I hear a lot, and I'll get down to the next question that I think Emily had in the chat, is people say, "Oh, this seems very rushed. No vaccine has ever been made this quickly." And what I tell patients is, there's never been a time in human history where all the money and science has been aimed at one problem. This is remarkable. There's no other time in human history, not even the space race, not anything, where all of science was really just aimed and focused on one specific thing. The other thing that happened that allowed these vaccines to come out very quickly is previously, the way that vaccines would be developed and studied is you would have very separate processes that were segmented, and you would have to cross one threshold to reach another step in the process of development. And they were very smart in the way they designed these trials and the way they designed the building of these vaccines, as they started to stack things and overlap. And so as soon as they saw something being effective, they could start the next part of the process, knowing that the rest of that data was going to come later. And then even whenever they started to have the efficacy data come out, they were already making large batches of vaccine. And so what they did is they stacked a lot of these steps on top of each other in a way that's never been done before. So Emily asks another question that I think is really important. And unfortunately, I think it was a week or two ago in the Post-Dispatch, they had the front page said, X number of people who have been vaccinated still get COVID. It's really unfortunate that that's the story that people have been leading with. What they should be leading with is the fact that the risk of death from COVID after getting vaccinated is almost zero. I had a patient the other day who is in his 80s, only got one dose of the vaccine before he got COVID. He also has a cancer, and he survived. I mean, that's unheard of. And he only had one dose of the Moderna vaccine. And so, he was talking about how lucky he felt to even have that dose, because he probably would have otherwise succumbed to his illness. And so there is a risk for two things to happen. One, to have mild disease. And that would be, to still have maybe a low-grade fever, cough, and B, to have asymptomatic disease. And so what that means is you might still have the virus replicate in your airways or nasal passage without you ever having symptoms. And we do know that happens when people have the vaccine. We know that the number of viruses that they produce or that you can recover from their nasal passage is much less. And so they're probably less infectious. But that's one of the reasons that we tell people who are vaccinated, but still interacting with unvaccinated populations, that they should still continue to wear a mask. And unfortunately, a lot of people, I think, have heard this message of, oh, if I get vaccinated, I still have to wear a mask. Oh, if I get vaccinated, I still might have a risk of getting COVID. And unfortunately, the signal that they're getting is the vaccine must not be that effective. In all honesty, this is the most effective vaccine we've probably ever created. And that's not hyperbole. As you navigate some of these discussions, I would give you some things that I've taken away from having a lot of these conversations with patients. One is the thing that might motivate us to get the vaccine may not be what motivates other people to get the vaccine. And so one thing that I've spent a lot of time realizing is that many of my patients aren't necessarily concerned for their own health, but if you talk about it in the context of their friends, their family, or being able to interact with other people in their social circle, after my family members got vaccinated and the CDC said that we, could gather without masks on, we were able to do that. And I think that I didn't realize after a year of not being able to see my family members how profound that would be for me, just to even be in the same room with them. And I explained that experience to patients and have actually had several of them go from not being that interested in the vaccine to getting vaccinated that day. So good question about, so the aborted fetal tissue. So there's no aborted fetal tissue that's used to make any of the vaccines. Very high upstream in the development of J&J, there was a cell line that may have been derived from cells that may have been from fetuses in the past, but none of that is actually in the technology that makes these vaccinations. And none of that is a part of the vaccine that you get. However, if people have that concern, some people have very strong religious beliefs. And so rather than, I tend to, in these conversations, try to roll with resistance. So instead of trying to push back on the concerns people have, I try to reframe them and say, well, if you have that concern about J&J, can we get you signed up to get Moderna or Pfizer? Because those vaccines had nothing to do with that. And so I know that people who are Catholic or may have some of those beliefs have been very anti-J&J. And so, and that's fine with me. And my goal is to educate people and to help them make the best informed decision for themselves, and not necessarily to browbeat them or to feel like that they're being coerced, because I think that just creates more barriers. Question about people who, so there's a question here about people who have previously had COVID getting the vaccine. So just because people have had COVID does not mean that they're not at risk for getting COVID. I don't know if many people have been following what's happening in India, but early on they had a wave of COVID in India, but many people had very minor infections. And so back in March of 2020, there were many people, and they thought that it was going to spread rampant, and people did have very minimally symptomatic COVID. And what they're seeing there is many people are now getting these variants of COVID, or are now having very severe symptomatic disease. And I've certainly seen patients that in March of 2020 had COVID and then come back to the hospital in December of 2020 because they have another infection. And so I think any opportunity to help your body have more immunity against COVID is good. Are you destined to get COVID a second time? I'm not sure. Are you destined to always have immunity if you get the vaccine? I'm also not sure of that. I will tell you what we don't see is people having severe reactions to the vaccine after having had COVID in the past. And I know that there have been people that have been worried about that, is what if I get re-exposed to this these spike proteins after having had in the past. And we don't actually see that as a clear signal. Yeah, so good question. So Emily's asking a question about who are trusted in helping encourage vaccination. So honestly, probably friends and family members and community groups. And so my clinic is largely made up of minority people. And so I try to be aware of the fact that as someone that does not look like them or that they might not identify with, that they may not be interested in what I'm selling them because they may have in the past had experiences where they felt like they were being sold things that didn't work out for them or their community. Now I do have many patients that trust me. And one of the things that I try to do is if I can break through to one patient, or if I have patients that trust me, is I say, tell your friends and family that you got this vaccine. Tell them that you would like them that you had a good experience with this vaccine. And my thought is that through more grassroots conversation, that we can dispel some of these myths rather than, before the call, we were talking briefly about vaccine education events that I've been doing otherwise. And I've started trying to move as many of those as I can to be like small in-person affairs, because I think having a conversation rather than someone that's just a talking head through Zoom or on a video is more helpful and allows you to meet people where they are. And so I think those things are helpful. I don't know that there's clear evidence about who people are going to trust or not trust, but I personally believe that it's often going to be people that either are within their family or social circle or people they feel like are coming from their own community. And so I've worked closely with Dr. Madi Shlotwayo, who works with the city of St. Louis and is a Black woman who's been doing a lot around healthcare disparities in general before COVID, but has certainly become a national figure there. And this is something that she also believes in that we really have to try to do whatever we can to meet people where they are, to address their questions. And at the end of the day, this is not an FDA approved vaccine. It's offered under an EUA, an emergency use agreement. And so it's not fair of us to browbeat someone into making a decision that they don't feel comfortable to make. And so I think as long as we can educate people and help them to make the decision that feels right for them and their family, that's the best thing that we can do. Questions about the, this is, Shardon is asking a question about the trackers in the vaccine. There was a lot of concerns about this early on. Honestly, as the population that I serve mostly are patients who use drugs, patients who are unhoused, and patients who are living with HIV. And when I talked to them about their perceptions, we just started, even before we had vaccines available, we started asking them about their thoughts about vaccines or if they would be open to a vaccine. And a lot of these questions or concerns actually weren't the concerns they were coming up with. The government sponsored the making of the vaccines, but did not have a direct hand in the making of them. And the way that it sponsored it is that they pre-ordered the vaccines before they were available. And so by saying that we're going to spend we're going to give you $1 billion because we're going to buy the first 100 million doses, they funded the vaccine. But it wasn't the government saying, standing over Moderna or Pfizer's shoulder making that. I will say government scientists, certainly the CDC also had a strong role in that, but we're doing that as individual bodies and not necessarily as like an entity in and of itself. The other, another thing that's come up frequently is about the vaccine and risk for infertility. There was someone who made a blog post early on saying that there was a risk for the vaccine to cause autoantibodies that might harm placentas. And that also has been disproven. And in fact, in the Pfizer studies, there were women that actually got pregnant during the study and people that actually delivered. And the one person that had any kind of pregnancy issues during the study actually got placebo. And so wasn't actually given the vaccine.
So Dr. Nolan, I referenced some survey data out of the Missouri Hospital Association that I've viewed in the past, and they suggest that people really do trust their primary care physician or other healthcare provider. Do you think there's any legitimacy in connecting those who may be unaffiliated with a primary care physician to kind of increase uptake, or is that too much of a zigzag line to the vaccine?
I think if people trust their primary care provider, it's probably been because they've been with that person for some time. And so my suspicion is that if you establish with a new primary care provider and the first conversation is about getting the vaccine, I don't know that it'll be any more successful than meeting with a community health worker or someone that is. But, you know, as much as I showed you a bunch of slides with graphs and figures and data, as humans, like, we don't respond to that. We respond to stories. And the thing that I think has moved the mark the most for some of my patients is telling them stories about, you know, I had one patient that came in and he was just so excited to get the vaccine because it was the first time they were going to be able to do, Easter was so important to him, and he was going to be around his mom for Easter, and she had already gotten the vaccine and he was waiting to get his. And so I then used that story when I talked with patients later on. I said, you know, I had a patient earlier today who was just so excited to be able to see his mom about Easter. And it's like those things start to click with people because they start to see the tangible benefits of getting a vaccine, which in many cases far outweigh any type of risk of harm, whether it's from this minuscule concern of blood clots or whatnot. So those are the things that I've tried to use to connect with patients. But I do agree with you that patients that have been my patients for a while, or patients that know me, are more likely to trust what I say. But when I have someone that's like there for an established care visit, it's less likely that I'm going to move the needle. And if you guys have, you know, at your organizations, you know, I've had organizations. So again, I work a lot with shelters and shelter providers. And so there are times that the issue isn't always necessarily their clients, but like the employees. And so we're happy to try to come and have and meet people where they are, as far as like talk with employees or talk with, you know, whoever your clients are. So if these types of conversations would be helpful. So question about vaccine hesitancy among minorities. So that's a very complicated question. There is a book that probably every person should read, especially anyone that works in the healthcare field, called Medical Apartheid, which, you know, a lot of people cite Tuskegee as a reason that minorities don't trust the healthcare system. And that's just like one example of dozens of things that we, unfortunately, as a healthcare system, really have to hold ourselves accountable for. And, you know, the disparities in vaccine access are a couple-fold. First, you know, if you don't have reliable transportation or you don't live near a healthcare system, it's not easy for you to go when Barnes has a vaccine day that you can go get a vaccine. And I encourage you to look at the racial profile of where people live in St. Louis, and then also Google where the hospitals are, because there's a stark contrast there between where the minority individuals in St. Louis live and where hospitals exist. And this disparity exists in many places across the US, very famously in Chicago as well. And so I think one, it's not fair always, and I'm not saying that this was the statement you were making, but I think it's easy for us to say, oh, minority people aren't getting the vaccine because they don't trust us, when I think we probably haven't done enough to take the vaccine to where people are. And so there's been a lot of conversations about how do we provide transportation to people that might not otherwise have it? How do we, again, I work a lot with unhoused people. How do we make sure that we're delivering the vaccine in a place that someone can get it? And that if we do think they might have low-grade fevers or feel crappy for 24 hours, that they have a place to stay and don't have to do that on the street. And so we as a society have to be thoughtful about that. And there's been a lot of conversations around that. And I think some places are doing it well. And I think we're trying to do it well, but we're certainly going to stumble along the way. And I think we just have to be humble enough to recognize that and to be able to say, and having community stakeholders that can help to guide us about how to do it the right way. So I think that's one part of it. And I think the other part of it is making sure that, again, that these things are a dialogue, and that if people don't feel comfortable because of something that they personally have experienced in the healthcare system, or their family members or their ancestors have experienced in the healthcare system, that we, again, start this as a dialogue and it's not a yes, no question. For my patients, it's, I do have patients that say, I don't trust it. And I say, okay, I care about you a lot, and I'm going to ask you again in 2 weeks whenever I see you. And hopefully you don't get annoyed with me. But I think as you, again, continue to have those conversations and say, call me if you think of a question, call me. I'm happy to look it up. If you want to go home and talk to your husband, I'll call you in a day or two. And I think those things, again, taking that pressure of you have to get it today because you're in clinic, I think helps people feel better about making that decision and not feel like it's a pressure situation. And maybe I completely missed the mark of that question, but I guess that's the way that I, as someone that, realizes I'm an outsider to many of these communities, has tried to deal with that. So if you guys have any other questions, I'm happy to answer them. If you feel like that there are things in this talk that would have been more helpful, or things that I talked about that weren't helpful, I welcome any of that feedback, either here or offline. Again, my goal is just to help educate people and help them make whatever is the best decision for them and their families. So.
All right, well, thank you everyone for joining us this afternoon. And again, I'll put my email in the chat. If you have any other questions, feel free to email me and I'll pass those along. And I hope you all have a wonderful rest of your day.
Thank you.
Thanks for having me.